We're going to talk today about the new classification system for periodontitis. This is the result of a world workshop in 2017 with the publication of the proceedings of consensus meetings globally in 2018. This represents the first full change in the classification of periodontitis in 2 decades. And as a result, it represents rather substantial change in how we think about periodontal disease and the treatment needs of our patients. The first question that we should ask, of course, is why should we change? We've been doing a very effective job for the past 20 years. What encourages or perhaps forces us to make this change? It comes down to some important recognition in the past 20 years. First of all, that not all patients are the same in terms of the trajectory of disease that they're following. And although our standard principles, which we teach very well in terms of managing periodontitis and preventing periodontitis, work well for about 75 to 80% of the population, they don't work very predictably for the other 20 to 25% of the population. And those are the individuals that we really want to make sure that we identify early and can distinguish based upon our diagnostic criteria. The other thing that we recognized is that although in the late 1990s we believed that the different clinical phenotypes, the different clinical appearances that we see in our patients were likely due to either genetic differences or microbial differences or something that we could measure that would predict those changes. In fact, we've learned over the past years that that is not a consistent finding, and that the reality of the model that we're in for periodontitis is what is referred to as really a chronic disease type of multifactorial disease process. You'll see what that means in just a moment, but it changes the way we think about translating what we see clinically to what we need to deal with from a treatment standpoint. And finally, we recognize that the severity alone of the disease lost some of the key dimensions that we need in terms of managing this disease process. So the new classification is much more robust than just severity of disease from the standpoint of how we assess our patient. Now, the multifactorial disease concept is important, and as you see in the slide, this is a cardiovascular disease study from many years ago, and it followed thousands of individuals over an 8-year period of time to see who had a major event of cardiovascular disease, with the main focus being their level of LDL cholesterol, of course the main causative factor in that disease. And it was understood that anything over about 160 milligrams per deciliter was bad and should be treated. As you see in this particular slide, in fact, it turns out that if we look at 160 above and below, that we see 2 very different curves in terms of the development of cardiovascular events. And individuals who are on the higher curve, in fact, have 6 times more events than individuals on the lower curve at the exact same LDL cholesterol level. So we know that there are multiple factors, without knowing necessarily what those are, that are influencing some individuals to develop more severe disease earlier and more likely given certain causative factors. And that seems to be the same case with periodontitis. So what's really different in the classification? The prior classification from 1999 is based almost entirely on severity of past disease destruction. The new classification uses past destruction and severity, but also includes other factors, including tooth loss, which can be important in terms of the real history of the patient, complexity of managing this patient, both from a future prevention standpoint as well as how we're going to treat and maintain them long term. And of course, we want to look carefully at the rate of progression, doing our best job with the data that we have to tag an individual patient based upon our estimate of their future progression with or without periodontal therapy. So the new classification has two components that are not unlike some of the structure with classifying oncology patients. So the first classification component is staging of the patient, and there our objective is really to understand severity, what they have currently, and understand the current distribution of disease and severity of disease in the framework of where the disease is in the patient, so we can assess the complexity of managing what we see today. The second component is a grading component, and that really is to assess on a variety of factors what is the likelihood of progression of disease if we use our standard principles of managing the patient. So do we have a patient who's less predictable in terms of response to standard principles of prevention and treating periodontitis? Likewise, the grading component in some patients we will use to assess how the patient's periodontitis may likely influence systemic disease and vice versa in terms of systemic disease affecting the periodontitis. Now, the first table is a bit daunting, and that is the staging table. And as you see across the horizontal axis at the top, there are 4 stages. And on the vertical axis on the left-hand side, you see the different criteria we use for classifying the patient. Most importantly, we don't want nor expect that as you're assessing a patient that you'll take some measurements and then start going down each column to see where that patient basically fits. That really would be very time-consuming and not very effective in terms of how we conceptualize patients from the standpoint of the pattern of their disease rather than specific millimeters of measurement. So we will think about this in a very different way. First of all, we're going to look at tooth loss, as we mentioned, and we're going to look at complexity of disease. I've drawn a red line on this slide in between stage 1 and 2 versus stage 3 and 4. As you see when you scan the columns in stage 1 and 2 versus 3 and 4, that those two groups are very, very different in terms of the complexity of managing those particular patients. And so we want to start by thinking about, is this a stage 1 or 2 patient, or is it a stage 3 or 4 patient? Because that determines to a great extent the knowledge, the experience, and the level of intensiveness that we will have to apply to managing the particular case. So our goal is identify periodontitis as early as possible and divide the patients up stage 1 or 2 versus 3 or 4, and I'm hoping to show you how to do that rather rapidly today. So first of all, we want to take a very high-level view of the patient based upon radiographs or based upon a probing chart, and we want to use what we see, as in this first example with some bite wing radiographs to say, well, this patient appears to have minimal disease, at least by the basis of radiographic assessment. That then allows us to say it's most likely a stage 1 or 2, and that narrows our perspective on the staging table in terms of what we need to focus on. So we can eliminate the stage 3 and 4 columns initially as we assess the patient. So we then look to see, is the complexity consistent with stage 1 or 2? What do we see to differentiate stage 1 versus 2? Or is for some reason that we've misjudged the case and we need to move it into a higher stage category? If the patient is more severe, even in a few localized sites, as you see here on this slide radiographically, then we are more likely to have to go into stage 3 or stage 4 in terms of classifying the patient. And once again, that greatly narrows our focus. Instead of being all across this table, we can now look at the case and say, is it stage 3 or stage 4? This one appears to clearly be in those two stages, one of those two. And then we want to look at the specific parameters and, most importantly, the complexity of managing the case, which will be the key determinant of is it stage 3 or stage 4 type of patient. Okay, now with those facts in mind, let's look at a few clinical cases. So this is the first case. This is a patient, 29 years old. She is a type 1 diabetes patient, not well controlled. The last assessment of her hemoglobin A1C measurement was 7.8%, so not the type of control we would like to see. She does not have as routine dental visits as we would like, and therefore we have that problem also. You can see in the clinical presentation of the case what the tissue looks like, various assessments. You can see there's a little calculus here and there, actually quite a bit on some teeth. And around the tissue you can see the inflammation and the change in the red color, as well as the conformation of the tissue relative to the tooth. On the lingual surface of the lower molars you can see some suppuration, also a different characteristic in terms of the color and the conformation of the tissue. As we look at a probing chart, you can see in this example that this particular patient has sites of probing depths that are not too great, and likewise with the clinical attachment level. And so we've summarized in the lower left corner of this slide the summary of what's there from our measurements. Likewise, there's not a lot of furcation involvement, some, not much mobility, just a little, and that's our general characteristics that we identify with the patient. So we would start based upon probing depths of putting this patient in a stage 2 from, and that's actually clinical attachment level, excuse me. So based on clinical attachment level, this patient would qualify for a stage 2 severity as the initial assessment of the patient. As we look at radiographs, and you'll see my little red 3-part step ladder, that's just a tool. You can use a periodontal probe, anything to assess the bone level and the bone loss relative to the entire root length. We recognize that the real attachment level begins 1 to 2 millimeters below the CEJ, but for this purpose we want a general assessment of bone loss relative to the entire length of the root from the CEJ to the apex. And so again, in this patient, we have a few observations. First of all, the patient has no tooth loss, minimal to no caries experience, and minimal bone loss in the top third, the most coronal third of the root length. And so that also changes our perspective a bit, refines our perspective relative to stage 1 and 2. And so we see that in fact it's in the coronal third from a standpoint of bone loss, coronal third of the root length, and it also, we have other information in terms of tooth loss. In this case, there is none, none attributable to periodontitis or actually to anything else. So this is how we would assess the patient. They basically, on the assessments we've done clinically, we would classify that patient as a stage 2 periodontitis patient. Next, we would go to looking at the complexity of the case. And here, although we've eliminated stage 3 and 4 considerations from our first assessment of this patient, we want to take a quick look at the complexity components of stage 3 and 4, because that could change how we classify this patient. So if the patient has some complexity factors which are due primarily to tooth loss or to some compromise in terms of mastication, then we might accelerate the staging to stage 3 or even stage 4 if there's a fair amount of tooth loss. In this patient, again, we have neither stage 3 or stage 4 complexity factors, so we would conclude that this is in fact a stage 2, and we would then go on to the grading aspect of this patient. With stage 1 and 2, we once again can focus in this grading table what's important to us. And we will primarily focus on the aspect of whether the amount of bone loss that's there is consistent with the age of the patient. The grading is grade A, B, or C. We would assume in all cases, starting with grade B, representing a moderate rate of bone loss, and we would classify the patient as C, a more rapid or more aggressive rate of bone loss if we see evidence of that, or downgrade them to grade A if the patient is of an older age and minimal bone loss that may have occurred much earlier without continued progression. So B is our starting standard assessment, and then we're looking to see if there's any greater indication of progression. In stage 1 or 2, we focus primarily on the level of bone loss relative to the patient's age. So in this case, the maximum bone loss would be the coronal third, so we could have 25–30% bone loss. The patient is 29 years old. So if we divide 30% by 29 years, then that would put us right at about a 1.0 rate of bone loss by age, or just a little over 1.0, and that puts us in the B range. So that's where this patient fits. The other thing we want to look at for stage 1 and 2 is whether the patient has risk factors, primarily smoking or type 2 diabetes, or actually type 1 is in this case. Patient is a non-smoker, so that's not a factor. However, the patient is a type 1 diabetes patient, and she's not well controlled. And so the hemoglobin A1C value puts her into a C category, and so we would now classify this patient based upon the most advanced state, and we would classify this patient as a stage 2 grade C patient. Now let's move on to the next case. This is a 49-year-old Caucasian. This patient has been a heavy smoker for many years, some osteoarthritis, but minimal drugs that are needed for that. And the patient has not been a good attender in terms of dental care, and so it's been actually several years since past attention to dental needs. So you can see the appearance of the tissues, very typical of a heavy smoker, what we would see. And this is pretty standard in this particular case. Once again, we happen to have a patient with no tooth loss. That is a bit of a surprise, but that's what we see with this particular patient. Now we have the charting of this patient, and so you can see with the clinical attachment level summary down in the bottom left corner of this slide that the attachment loss goes up to about 9 millimeters of measurement. And now we have more furcation involvement, a little more in the way of mobility than we had in the prior patient. So when we look at our severity in terms of attachment level, this patient now fits into stage 3 or stage 4. Notice that the measurements are the same for stage 3 or stage 4 because we're going to differentiate stage 4 from 3 based upon complexity and other factors. So as we go now into the radiographs, you can start to see that this patient has some bone loss into the middle third of the teeth. And we want to measure the most severe bone loss that we find in the patient in order to see really where they are from a classification standpoint. So we, once again, based upon the radiographic bone loss, would put the patient in the stage 3 or stage 4. And you'll also notice that because there's no tooth loss with this patient, the tooth loss component is actually stage 1 or stage 2. But we don't worry about that difference in terms of where they should be classified because we want to classify by the most severe disease that we identify in the patient, and that's stage 3 or stage 4. So now we want to look at complexity of the case, and that's the real distinction between these two stages. And as we see, this patient, because they do have some furcation involvement, some vertical bone defects, but they do not have missing teeth. And it's the missing teeth and the challenge to the dentition and the mastication where we get into a stage 4 level of complexity. So this patient will qualify as a stage 3 case, and it really allows us now to move into the grading of this patient. This patient, once again, 49 years old, but the bone loss is somewhere in that coronal, in that middle third of root length. So we could be somewhere around 50% bone loss at the most. And in a 49-year-old, once again, we're back in the B area in terms of grade with a ratio of bone loss of somewhere around 50%, I'm sorry, not 50%, 1 in terms of the ratio. Likewise, when we look at the risk factors and other components of the grading system, which we need to do in someone with stage 3 or stage 4 periodontitis, we have a heavy smoker. And so although this patient has not lost a lot of bone or teeth at this stage, we still have someone with a major risk factor for future disease progression, and inherently this patient is less predictable in terms of treatment outcomes. Because with the new classification system, we will be assuming, as the clinician, our management of the patient long-term based upon our initial assessment. And so we would look at this patient, as shown in the description on the left of the slide, and say this patient has major risk factors. They're 49 years old, and the bone loss is moderate to severe, and it is likely, or at least possible, during the next 10 years of this individual's life, due to the smoking and due to the severity of bone loss at this time, that we could start to see much greater problems, moving this patient into a greater complexity of management. And because of that, we want to upgrade this patient to a C category in terms of grading. And that means that we're assuming responsibility for a patient who is more likely to progress even with good principles of care, and therefore we want to see them more frequently, and we want to consider more intensive therapy as that may be necessary based upon our monitoring of this particular patient. So that's the way we think about this disease in the new classification. It's very different than just measuring the past severity of destruction, especially as you see in these two cases based upon risk factors that they have. I'd like to thank the 4 schools that have been fantastic from their perio departments in providing cases. We used 2 of those today, and certainly these cases are fantastic in terms of demonstrating how we think about the classification process. Thank you very much, and I wish you well in terms of moving into the new classification. Thank you.